Generally, this is how you use an AED in special circumstances. Most generally, one EMT operates the defibrillator while another one does CPR. CPR must include high quality compressions. Defibrillation comes first. You must be familiar with the model of AED used in your area. All contact with the patient must be avoided while they're analyzing. So check rhythms, don't touch the patient. Pulse checks should not occur while the rhythm is being analyzed. When you're getting ready to shock somebody, state clear and be sure everyone is clear of the patient before you deliver the shock. Check the batteries for an AED at the beginning of your shift and carry spare batteries. If you have delivered 3 shocks and are without a backup, prepare the patient for transport. An AED is often not able to analyze the rhythm accurately in a moving emergency vehicle, so you might have to pull over to get a better recognition. Coordinate with your ALS personnel. Notify as soon as possible to be able to rendezvous with them, or if the hospital is closer, get them to the hospital. If the team arrives before you have finished the first shock, they should allow you to complete that shock. Your actions can depend on location of the arrest and estimated time of arrival of the ALS team. Coordinate with others who defibrillate before you arrive. Let the operator of the AED complete the shock before you take over care of the patient. You may need to take the first AED to the hospital with the patient so data can be retrieved from the machine. This is not the case in our situation. Your protocols will dictate transfer of care. If a patient has a pulse, manage the airway. Don't overventilate them. Keep the defibrillator on the patient during transport in case the patient goes back into arrest. Reassess frequently, every 5 minutes, and consider hypothermia protocols, if that's in your protocols. If a patient has no pulse, you'll need to resume CPR. An AED will give you a no shock indicated message. AED may be prompting you to analyze the rhythm because it thinks there is a shockable rhythm. Ensure adequate ventilation and oxygenation. Adjust the amount to no more than what is necessary to achieve oxygen saturations of above 94%. Protocol may require you to place the patient in the therapeutic hypothermia. There's a pre-hospital machine that they've been studying on hypothermia, and there's some areas that will tell you to put ice packs in their groin and under their armpits to try to start to cool them. In that respect, studies are still being done, so not everybody has bought into trying to do the hypothermia, and it's not being done in the NAVU system. So use techniques of lifting and moving so that you're doing it safely. If the patient goes back into cardiac arrest, stop the vehicle and resume CPR. Have someone else start CPR if the AED is not immediately ready again. And then as soon as you get it ready, analyze the rhythm and deliver a shock. Continue with 2 shocks separated by 2 minutes or 5 cycles of CPR. So, if you have a person that goes into arrest in the ambulance, there's really no guarantees, but you have a really good chance of reviving the patient because you can defibrillate a lot quicker. Generally, within the first couple of minutes of cardiac arrest, people are in a shockable rhythm. They're in ventricular fibrillation. For every minute that a person is down, you lose 10% chance of their survival. So after 10 minutes, you've pretty well used up their chances of survival. So if they go into cardiac arrest in your ambulance, you're right there. You have a good chance of resuscitating them. Stop the vehicle and treat this patient like any other patient in cardiac arrest. Single rescuer with an AD. Apply the AD and defibrillate immediately. The defibrillation is so important. Once the shock is delivered or received, or if you got a no shock indicated, begin chest compressions. After about 2 minutes, check the rhythm again and shock is needed. Some contraindications to using the AD. If the pads won't fit on the patient without touching each other, you should not be shocking if there's no space in between the pads. On kids, you can put the pads one in front and one in back. Trauma with severe blood loss or damage to one or more vital organs. Very poor chance of survival in a trauma arrest. And hypothermia, you may not defibrillate until you've warmed them up a little bit. So do not defibrillate soaking wet patients. That's dangerous. Dry them off. Do not defibrillate if the patient is touching anything metallic that other people are touching. Remove nitroglycerin patches before you defibrillate. Verbally and visually clear patient before you defibrillate. Make sure everybody's is clear. So be safe when you're operating a defibrillator. If there's implants or surgeries, a lot of times there's an implanted device like a pacemaker. Generally, they put it on the left side, a little left side of the chest underneath the skin. It feels like a little square lump. You can still use a defibrillator on them. Just don't put the AD pad over the over the device. Not a problem if it's on the left side, but on the once in a while, the patient that has it on the right side, you might have to move the pad so it's not covering it. So position the defibrillation pad on patient's chest to avoid contact with the device. Some devices and surgeries you may observe in the field might be a cardiac pacemaker, an implanted defibrillator, another thing called a ventricular assist device, which is very specific. You don't generally give typical CPR with a ventricular assist device. Cardiac bypass surgery might be another thing you'll see where they've actually gone in and opened up their chest. So, in quality improvement, multiple functions here. Medical direction will review cardiac arrest protocols and initial training and maintenance of skills. They'll do case reviews every so often, trend analysis, and any way that you can strengthen the links in the chain of survival in our area is a part of quality improvement. Maintenance. Use a checklist at the beginning of every shift to ensure you have all supplies and AD is functioning properly. Make sure the battery's charged and you have a spare with the defibrillator. Mechanical devices assist EMTs to provide high quality compressions. There's another thing called the Lucas CPR device that does automatic CPR. You stop CPR just long enough to put the Lucas base plate under the patient, and then you stabilize the strap before moving the patient. And upon termination of arrest or return of spontaneous circulation, you power down the device. There's another one called the auto pulse. You align the patient on the auto pulse platform. You provide bag mask ventilation at a rate of 2 ventilations for every 30 compressions. After 2 minutes of CPR, reassess for a pulse and shockable rhythm. Once you start resuscitation, you need to continue unless they get a return of spontaneous circulation, something that they call ROSC, R-O-S-C. Spontaneous circulation occurs, then you just need to give rescue breathing if they're not breathing adequately. And you can terminate resuscitation if another trained rescuer takes over, or if they get more circulation, they get ROSC. Terminate resuscitation if you turn care over to a patient, turn patient care over to a person with a higher level of training. if you're just too exhausted to continue, or if you have a no resuscitation or DNR order from a physician or other authority. Once you start resuscitation, you must continue until there's criteria to determine when it's reasonable to stop without missing anyone who has a chance of survival. So if it's an arrest not witnessed by EMS personnel or first responders, there's actually a protocol that you can look at. If you can document they've been in arrest for longer than 15 minutes, then generally that's a reason not to start CPR. Once you start resuscitation, you must continue until there's a reasonable reason not to. Maybe they're not going to survive. Maybe their injuries are incompatible with life. If the AD didn't detect a shockable rhythm and did not deliver any shocks for a period of time, and you're not able to get the patient out of a certain location or whatever, you might be able to call medical control and get permission to stop.
A healthy heart pumps regularly at various levels of exertion and coinciding heart rates. Cardiac arrest occurs when the heart stops pumping correctly. Chaotic electrical activity throughout the heart causes uncontrollable fluttering or ventricular fibrillation. The heart beats erratically, no longer pumping oxygen-rich blood around the body, which starts to shut down. Automated external defibrillators are designed to shock the heart back into its normal rhythm. Placing 2 monitoring electrodes on the chest, the AED measures the electrical activity of the heart, analyzes the cardiac rhythm, and determines whether a shock should be administered.
Cardiac arrest, the cessation of the forward movement of blood from the heart, can occur when massive myocardial infarction results in dead myocardium, which is unable to contract despite continued firing of the SA node. In addition, dysrhythmia, such as ventricular fibrillation, can result in inadequate stroke volume and the cessation of forward movement of blood from the heart.
Of automated emergency defibrillators, or AEDs, as life-saving devices is becoming more and more common. An AED sends an electrical current through the myocardium of the heart, briefly causing the heart to stop and allowing the heart's natural pacemaker to take over. The AED is brought by a second or third-party rescuer after the initial chest compressions and rescue breathing have begun. Place the AED next to the victim's left ear. This position allows the rescuers clear access to the chest and airway for continued rescue measures. Turn the AED on and follow the voice prompts. You will be prompted to attach the electrode pads to the patient's chest, on the sternum, and at the apex of the heart. Follow the diagram for correct placement. The machine will analyze the heart rhythm to determine if it is a shockable rhythm. CPR should cease while the machine is analyzing. The machine will charge and warn rescuers to stand back. The voice prompt will then tell you to press the shock button to administer the electrical current. If the machine indicates no shock is advised, assess the patient for breathing and circulation. Continue CPR as needed until advanced medical personnel arrive.
Coronary heart disease, CHD, also referred to as coronary artery disease, CAD, is the most common type of heart disease.
Coronary artery disease is a plaque buildup within the arterial wall that can start from anywhere from birth if it's a hereditary problem, or it can go with the aging process depending on how many risk factors that individual has not done necessarily correctly. The big 3 are hypertension, which is high blood pressure, smoking, and high cholesterol. If you think about the heart as a pump, because that's literally what it does, and the blood vessels are the pipes that the pump has to pump to, if the pipes narrow over time, and the aging process, with the aging process, we start out this world with elastic blood vessels, and they become more firm, like a pipe, as the person ages. You can prematurely create that elasticity loss to a pipe-like problem with atherosclerotic vascular disease. So if you can think of the concept of a tube this big and a tube this big, it is much harder for the blood to get through a smaller tube, especially one that's not elastic and cannot adapt to the increased flow that you need.
CHD is a progressive disease increasing the risk of myocardial infarction, heart attack, and sudden death. Symptoms vary, but include angina or chest pain, shortness of breath, and may be accompanied by swollen feet and ankles. Coronary heart disease is the leading cause of death in the United States. About every 29 seconds, someone suffers from a CHD-related event.
So, patients with cardiac compromise or acute coronary syndrome can have many different presentations. Some complain of pressure or pain in the chest with difficulty breathing. Others may have just mild discomfort that they ignore or that just goes away and then returns later. Between 10 and 20% of heart attack patients have no chest discomfort at all. They have the silent heart attacks. Because of these possibilities and the severe complications of heart problems, it is important to have a high suspicion and treat patients with these symptoms for acute coronary syndrome. The treatment will not hurt them and may actually help them. Patients who suspected acute coronary syndrome, who are hypoxic or short of breath and need oxygen and prompt, safe transportation to definitive care. You may be able to assist patients who have their own nitroglycerin in taking it, thereby relieving pain and anxiety. To provide maximum chance of survival for patients in cardiac arrest, EMS agencies must strengthen their performance in the chain of survival. The chain of survival links are immediate recognition and activation, early CPR, rapid defibrillation, effective ALS, and integrated post-cardiac arrest care. The heart is a simple pump that moves deoxygenated blood to the lungs and oxygenated blood to the body. Pressure within the cardiovascular system is critical to the moving of blood. Acute coronary syndrome is a blanket term that refers to a number of situations in which perfusion of the heart is inadequate. Although there are common symptoms of acute coronary syndrome, EMTs must recognize atypical findings and err on the side of caution. Oxygen, nitroglycerin, and aspirin are key medications indicated to treat acute coronary syndrome. However, the definitive treatment is transportation of the patient to a facility that can open the blocked artery. Most cardiac conditions are caused by arterial problems. Angina pectoris and acute myocardial infarction are caused by inadequate perfusion of the heart. Heart failure can be caused by either electrical or mechanical problems. The most important element of cardiac arrest care is the administration of high-quality chest compressions. The American Heart Association's chain of survival describes the key elements necessary to maximize the cardiac arrest patient's chance of survival. AED provides early defibrillation in cardiac arrest patients with ventricular tachycardia and ventricular fibrillation. Post-cardiac arrest care is an essential element of cardiac arrest care. Mechanical CPR devices provide automated chest compressions in cardiac arrest settings. What position is best for a patient with difficulty breathing and a blood pressure of 100/70? Probably sitting upright a little bit to help their breathing. Chest pain and a blood pressure of 190? Their blood pressure is a little bit high. Um, but they're having chest pain, probably the position of comfort, just like in the first question, position of comfort. Describe how to clear a patient before administering a shock. That means you physically look and make sure nobody's touching the patient before you deliver a shock. List 3 safety measures to keep in mind when using an AED. Check for water, check for nitroglycerin patches, make sure they're not touching metal, dry them off. Now, can you list the steps in the application of an AED? If not, can you remember the first step? Turn it on. So a 78-year-old male has been complaining of severe shortness of breath for 20 minutes prior to your arrival. When you arrive, you find the patient unconscious and not moving. What are your immediate priorities?